Good morning. My name is Bethany Shirley. I am one of the staff educators at Overton Brooks, and today I'm going to be presenting HRO baseline training for frontline staff. This is a course that you are going to receive credit for in TMS and either myself or one of the educators will go in TMS, and we are going to give you completion for this course once this training is complete. Good morning. My name is Good morning. My name is Bethany Shirley. I am one of the staff educators at Overton Brooks, and today I'm going to be presenting HRO baseline training for frontline staff. This is a course that you are going to receive credit for in TMS, and either myself or one of the educators will go in TMS, and we are going to give you completion for this course once this training is completed. Let's go ahead and quickly review our agenda and objectives for today. Our class is 90 minutes long. What we're going to do today is we're going to provide a brief overview of what an HRO is and why the VHA is on the journey to high reliability. Then we're going to discuss the role of what is just culture in a high reliability organization and how can we as team members foster that. I'm going to share some simple tools that you can start to use that are going to reduce harm, and we're going to be able to learn how to analyze errors and improve processes. And we'll end with what comes next for the VHA on our journey to high reliability. I do want to say thank you for everyone for sitting in these classes. I know sometimes they can be long, and I understand that, but it's so important that we engage in this training and that we learn how we can be a part of a high reliability organization. And you're going to learn that the VA is dedicated to this process. It's something that they focused on, and it's really been a foundation of what the VA wants to do. Let me go ahead and introduce myself a little bit further. So I am a registered nurse. I've been one for 16 years, and for 10 of those years, I've actually been a nurse practitioner. So I do have a clinical background, and a lot of my nursing was actually in pediatric intensive care. So I will be sharing some stories about my background. One of the things that has been found when you're teaching stuff about safety, sometimes sharing a personal safety story can help bring people where they really comprehend it better and helps bring to their foremind that our first priority should always be to first do no harm. So when I had first started my career, I was actually working on a pediatric unit, or pediatric floor as you may call it, med surg floor. And I worked with the team, a great team. And one day I was getting some medicine out of the Pyxis machine for my patient. I went to get some Motrin, and I opened the drawer up and given some Motrin. My patient had a fever, and I look, and the Motrin looked different. Normally it was in a little teeny tiny medicine cup, pre-filled medicine cup, and you would draw out the amount you wanted in a syringe. Well, this was different. This was like a bright orange syringe. And I was like, what in the world? So I pick one up and I look at it, and it says diazepam. And I thought to myself, what? And I looked again, and I'm like, did I choose the wrong drawer? Let me shut this machine, tell the machine I'm not going to take anything out, shut the machine. Let me start over, click on I want some Motrin for my patient. Same drawer opens and it's diazepam, and I'm like, this is not good. So I go to one of my coworkers and I call her by name and said, come here, come look at this. And I show her, click Motrin, machine opens. I said, look at what that is. This is diazepam. And she was like, wait, what? And I said, yeah, look, it's diazepam, which is an anti-seizure medicine. It's definitely not anything close to being Motrin. And she's like, oh my gosh. And I'm like, what? And she said, I thought that was just new. I thought that was how Motrin was coming out. I just gave that to my patient. Like, oh no. Well, it's definitely not Motrin. So she, being a good nurse, she Immediately went to check on her patient, number one, that she had given the medicine to, the wrong medicine, called the physician told her some things to do, and this everything turned out okay. Patient tolerated it well, the situation was okay. But the thing was, there were several problems that occurred that day. Somebody put the medicine in the wrong drawer and it was labeled as such. The nurse pulled the medicine out and she didn't do all the things that she was supposed to do to administer the medicine. And that could have been a really bad event. Thankfully, she did do some things right. She felt safe enough with the environment that she was in that she could immediately own up to the mistake. She immediately told me. She didn't try and hide it. She immediately went and checked on the patient, and then she directly after that called the doctor. And so those were all good things. But you can see how safety is such a big deal, and things can become unsafe very fast. And so that's really what our whole goal of having a highly reliable organization is, that we are safe when we provide care, and that we have plans and processes in place that we can stop things from ever getting to the patient and ever harming the patient. As I'm sure many of you know, medical errors are a tremendous problem in the US. So there's a recent study that actually shows that they estimate 400,000 US deaths occur per year involving medical errors. That's a lot. And let's say that estimate of 400,000 was off by 50%. So now 200,000 deaths. That would actually be the same as if every single day a 747 jumbo jet that was fully loaded with passengers crashed and killed every single person on that plane. That would happen every single day. And we would be so alarmed if every single day we turned on the news and there was another plane that crashed. Well, we're not having planes crashing, but we are having 400,000 US deaths a year related to medical errors. That's a lot. And then it's not just the deaths. We actually have 1 in 10 patients that suffer an adverse event during hospitalization. 50% of surgical procedures involve a medication error and or an adverse drug event. That's alarming. Makes you not really want to go in for that elective procedure. And then there's 4,000 surgical never events every year. So we know that we've made progress on our goal of always being safe and being highly reliable. But in healthcare, we've got a lot we've got to work on. So we've got to work on poor communication. We've got to work on understaffing and distractions and people not communicating well. We've got a lot of work that we have to do. What I'm going to do now is I'm going to show a video, and it is going to describe how medical errors can actually impact a patient. And so this video shows some graphic images. It's about 4.5 minutes. So if you get squeamish, you may want to turn away. And then we're going to talk about this patient's experiences.
Just as the nurse was about to put down the white padding that was over my incision, my mother said, "Wait a minute, there's something on her stomach. Looked like a mole." And my mother asked the nurse to call the doctor to come back, and she didn't want to. She said, "I am not going to call the doctor for what's going to turn out to be nothing." My mother said, "I'll call the doctor." I'll never forget, I was looking at my doctor and I raised the gauze and I just saw his face completely change. And when I looked down at my abdomen, the black dot was gone and there was a quarter-sized pustule. The infection kept spreading and it was starting to go down my leg. Over 2 million patients a year get hospital-acquired infections. I ended up having 6 more surgeries, 9 blood transfusions. I left the hospital with an open abdomen that took 3 years to close. My hospital, they were cited for being in violation of 5 state laws and 10 federal laws for unsanitary conditions in their operating rooms. It took me 10 years of almost weekly physical therapy to get back to a new normal life. I spent this past year, 2017, fighting for my life all over again. I went to the hospital with a sinus infection, and they said, okay, we're going to keep you because it looks like you're starting to be in the early stages of sepsis. Well, the next morning, the infectious disease doctor came, and he said, oh, great news. We're going to send you home. And I said, really? And he said, you know my history. I said, I'm a survivor of sepsis, Pseudomonas, MRSA, VRE, and necrotizing fasciitis. Can we wait until my labs come back before you discharge me? And, you know, I'd like to see what some of the cultures are saying. And he goes, oh, we didn't do any cultures. We don't need that. And, you know, we did a test for pneumonia and influenza, and you're fine. You don't have those. So we're going to go ahead and let you go home. And I said, well, can I get a second opinion on that? Can we talk to someone about that? And he said, I'm the best infectious disease doctor in the Valley, probably the state. Any other doctor is going to tell you the same thing I'm telling you. I ended up having 2 more surgeries, 2 more blood transfusions, deep vein thrombosis, blood clots in both arms. I was right back where I was 5 years before. And it really cemented for me the need to change the way we teach doctors, the way we treat doctors, the way they interact with patients and patients interact with them. We need to start sharing patient experience with our medical students, with our nursing students, so that they can get it from the horse's mouth.
When you're building your house, your profession, you want to make sure that you build it on a solid foundation of patient safety.
It's a major reason why we've seen 50,000 fewer preventable patient deaths in hospitals. And if you want to know what that means, ask Alicia Cole, who suffers the long-term effects of a hospital-acquired infection.
You know, we've learned a lot in healthcare, and we're better than we were 10 years ago. We're doing great at talking about patient-centered care. We're doing great at talking about preventing errors. We've got to do better in the action of it.
Every time I see that video, I just think, wow. And I think we can all agree that the system failed Alicia, that she had things that could have been preventable, that she did not have to suffer what she had to suffer. We saw where there were 5 state laws, 10 federal laws that were all cited because of unsanitary conditions. We saw where the provider dismissed her and they didn't consider her history and consider what she had been through. So there was a lot of room for improvement and a lot of errors that were made that really led to a lot of harm for this patient. Alicia's story that we just watched, it is an extreme example, but it's really not that rare, unfortunately. I want you to think of these questions that I'm going to ask you and just answer them and think in your mind about them. Have you personally experienced a medical error? Have you had a family member or a friend who experienced a medical error? Have you, as a clinician or a healthcare professional, have you been involved in a medical error? And I would guess that a lot of people could at least answer yes to one of those. And so this is why we are taking a hard look at our system and seeing how to use high reliability principles to reduce error. So what is an HRO? What is it? Well, an HRO it's an organization that experiences fewer than anticipated accidents or events of harm despite operating in a complex high-risk environment. So the ultimate goal of HRO is zero harm, and we're never satisfied with the current level of safety. We really, really, really always want to improve. So even if it's just one patient or one staff member that's harmed, that's not good enough. So our goal is zero harm. Now, notice that I'm saying zero harm, not zero mistakes or zero errors, because all humans make mistakes. And HROs know that, and they assume that people are going to make errors. It's just inevitable. But what's not inevitable is that these errors will make their way through the system of safety mechanisms that we have in place and ends up reaching the patient and causing harm. HRO focuses on 3 areas or pillars to help them achieve greater reliability. So the first one is leadership commitment, a culture of safety is the second, and continuous process improvement. So the first one with your leadership. So if you have a high reliable organization, your leaders are going to really commit to the goal of zero harm. So they have to empower their staff to feel like they can speak up if they see harm, that they can look for ideas of improvement. So that's what having leadership involved is. So you're going to see that the leadership are going to be rounding, that they're going to come around to their staff and they're going to listen and they're going to respond to safety issues and they're going to say, what happened? And they're not going to say, who did it? Whose fault was it? That's not what they're going to do. And then with our second pillar of culture of safety, it's what we're really going to talk about a lot. And so it means that we foster an environment or a culture that's safe. And so all staff feel like they can voice their concerns, no matter who they are, from the top to the bottom. And they also know that the response to owning up to an error is not punitive. It's not going to immediately punish you. And so staff members are able to participate in something called a root cause analysis, also known as a RCA. And so they can look at what happened and then they can feel safe if they realize, oh, I made an error. They can own up to that. And so that way that they can make improvements. And then the third pillar is called continuous process improvement. And that's where you're saying, well, what can we do better today that gets us closer to even zero harm? So HROs ensure that all staff members have tools to continually improve their work processes. And so many of you I know are already practicing continuous process improvements and you may not even realize it. You are involved in always trying to do better and always trying to improve our work so that we can make sure that our patients are safe. So the next thing I want to do is talk about something called the Swiss cheese model. And so it's going to illustrate for us some principles and some things that we can do to help have a high reliable organization.
Probably the most important foundational thinker in the field of patient safety is a gentleman named Jim Reason, who's a now retired or semi-retired psychologist in Manchester, England. What Reason was doing was, as a psychologist, studying what he called organizational accidents. How did terrible errors and accidents and harm happen in industries, whether it was nuclear power or space shuttles or intelligence failures in the CIA? So he studied a bunch of them, and what he found was the same pattern over and over again. What he found was, if you look at it superficially, you would see a human being who screwed up. That was the superficial understanding. It was easy because it fit with a human model that I need to blame somebody, and if I could just point a finger, I've solved the problem. What was really right was that in unsafe organizations, these organizational accidents happen because of a long chain of events that allowed that human error, sometimes several human errors, to cause terrible harm. So he came up with a model that, to me, I remember the first time I read this, it's called the Swiss cheese model. A little light bulb went off and I said, aha, oh, now I get it. And now I look back on errors that I've seen through my entire career, and now it makes sense. Organizations build in protections to block those simple human glitches from causing harm. The problem is those layers of protections he likened to pieces of Swiss cheese. They all have holes. If I kind of blow something one day, I forget something or write something in the wrong space, most days that first layer of Swiss cheese blocks it. But on a bad day, the first layer misses. It goes through the hole and it hits the second layer, and the second layer blocks it. When we kill someone in medicine because we gave them the wrong medicine or cut off the wrong leg, or there's a space shuttle crash or 3 Mile Island, and you look back, you realize there were a lot of layers. Each one of them had a lot of holes, and also that particular day the karma was pretty terrible. And it just happened to be that all of the holes aligned. And that's how the error made it through all of these, quote, protections to cause terrible harm. My instinct was no longer, let me figure out who screwed up. My instinct was now Swiss cheese. It became automatic. Here's a bad error. What's the Swiss cheese? What are the layers of protection that we had, that failed? How do we shrink the size of the holes? And how do we create enough overlap in layers of cheese so that an error never makes it through all those layers to cause terrible harm?
So as noted in the video, it is rare that all our defenses fail us, but sometimes on our worst days, those holes in the Swiss cheese, they all line up, and then an error actually reaches the patient that can cause an adverse event or some sort of harm. And so, like for Alicia Cole, everything kind of lined up that day, and you see what happened in the experience that she had.
Probably the
So let's kind of dig into these concepts a little bit more. So let's think of some examples or some slices of the Swiss cheese that we have in place to keep ourselves and keep our facility safe. So we have things like policies and procedures and professionalism and equipment, and we have our team members, and we have competencies that we keep up to date. Those are all these systems, these layers that we have in place that hopefully we can keep harm if we go through all of these steps, and we can stop an adverse event. What happens though is that unfortunately sometimes on a really bad day something happens and all these layers they're not in place, and so it makes it a lot easier for harm to come through. So for example, if you have an environment, you have all kinds of interruptions and you have noises, and so then something gets missed, and then with policies they're hard to understand or they're poorly written, and then something gets missed again, and then you have a culture where if I make a mistake I'm going to get in trouble, and my bosses don't treat me right, and then something bad happens, and you see as on and on and on things all happen with these processes and these layers, and then ultimately at some point in time something gets through, and then we have our adverse event. So the problem is that if we don't know about these holes and we don't know about the issues in these layers and these processes, because maybe there's no trust and people aren't comfortable and they don't speak up, then we can't fix the process. And so that's why we want to build something called a just culture, so that we want people to feel safe, so that if they see something wrong with the environment, or if they see something wrong with the policy, or they see something wrong with the equipment, that they feel safe enough that they can speak up, and then something can change, and then we can hopefully prevent an error and an adverse event happening to a patient or even a staff member. So let's talk about a just culture. I just kind of mentioned a just culture. What is a just culture? Let's watch a video that introduces the concept of just culture from an employee's perspective. And so this is a story about a nurse named Annie. She's from Washington, D.C., and she was involved in a medical error.
A patient care technician came to me and she told me, I need to let you see this screen. And she showed me the glucometer.
She saw the word high flash on the screen, and that's what she assumed was the result that she had.
She's like, I just feel like my blood sugar is really high. She's like, I don't feel good. I know my body.
And so there wasn't really any suspicion that it would be low. And so when this error message comes up, it kind of confirmed that.
So we rechecked her blood sugar, and the same thing popped up. So I covered her with some insulin, and I called the physician, and by the time I got her back in bed, she became like non-responsive. During the rapid response, we checked the glucose twice, I believe, and the same thing kept popping up, the screen that said glucose greater than 600. The next day is when I received the call. The patient care technician came to me and she told me, I need to let you see this screen. And she showed me the glucometer.
She saw the word high flash on the screen, and that's what she assumed was the result that she had.
She's like, I just feel like my blood sugar is really high. She's like, I don't feel good. I know my body.
And so there wasn't really any suspicion that it would be low. And so when this error message comes up, it kind of confirmed that.
So we rechecked her blood sugar, and the same thing popped up. So I covered her with some insulin and I called the physician, and by the time I got her back in bed, she became like non-responsive. During the rapid response, we checked the glucose twice, I believe, and the same thing kept popping up, the screen that said glucose greater than 600. The next day is when I received the call that the whole time her blood sugar was actually critically low.
Shortly after this particular incident, another nurse made the same error where the machine it was an actual low value, but the machine read off this alert saying for a high, do X, Y, and Z.
It never came to mind that the glucometer was incorrect. It was probably the worst experience I've ever had in my professional career.
The nurse manager called our human resources department, explained the error, this is what happened. We didn't fully understand the ramifications of this piece of equipment and the message that it displayed. And they said, well, I think you need to suspend her until an investigation is completed.
I felt like I was talked to like a 5-year-old. I wasn't talked to like an adult. I mean, I'm a nurse because I come to take care of people. I come to do my job. I'm very passionate about what I do. And for a long time, it really shook me. Like when I came to work, I was scared to like take care of patients, and I was really apprehensive about everything I was doing. I wasn't really confident anymore. It really shook me to the core.
I got a call from the chief nursing officer at one of our hospitals saying that they had a case. There was a design issue that might have contributed to the case, and they wanted us to take a closer look at it from a human factors engineering, safety engineering standpoint.
It quickly became apparent that there was more to the story than just that she had made a mistake, and that there was a lot more, that it wasn't just her. It was the actions of lots of people that led to this hazard, and it certainly could happen again.
You can't fault any one individual. That's a process problem that needed to be addressed. And the more we thought about it, the more we decided that we needed to fix the process.
The concept of high reliability, the concept of systems problems versus people problems, the concepts.
So what do you guys think about this story? So initially, we see that really Annie was kind of accused of making a bad error. And if you kind of follow the story, we found out it really was something with the equipment, the way the equipment looked, and what the nurse saw on the actual machine that checked blood sugar. It looked like the patient was having really high blood sugar. So she gave her insulin multiple times to try and get the blood sugar down, because multiple times it looked as if the patient was having very high blood sugar. But ultimately they ended up finding out that really the patient had low blood sugar. So by them giving her insulin, it made the patient very, very sick. And so we see though that what the leadership where Annie worked did was initially they reprimanded her and they accused her and they said it was your fault. And that really wasn't a just culture, but thankfully there was some further investigation and they were able to come and realize there was really a problem with the machine, and that could be fixed and could be handled, and that way other people wouldn't experience the same thing. But initially, if you worked with Annie and you saw how they treated Annie, would you want to tell a mistake? Probably not, because you would be afraid that, well, if I owned up to this error or this mistake, I might get reprimanded and disciplined just like Annie. So we see that wasn't very much a just culture. So that's not what we want. We want it to be where we can own up and we can find errors, and then things can happen and processes can take place so that we can become safer and that we can make sure that our patients are prevented from having adverse events happen to them. So what does a just culture mean for us at the VA? So if you look at the VHA HRO mission statement, you're going to see that it's where the leadership create and sustain a safe culture, and one that employees actively report safety concerns without fear. So we don't want a culture of blame and shame, because that encourages people to hide things. We want to foster a just culture so that people feel safe about detecting issues, and then that way we can figure out where harm could be coming from. So that's really what a just culture is, and that's one of the key principles for HRO. What I want to do now is I want to kind of shift from talking about just culture, because it's really important. But I want to talk about two fundamental paradigms or ways of thinking that we have to understand for us to really understand how we can become a just culture. So the first thing I want to talk about is human error, and is zero error possible? And are there certain errors that we can say will never occur? And so really in a just culture, we believe that human error is inevitable. It's ubiquitous, which means it's everywhere. And human error is not a choice, and no one is immune. No one, not even the best person. That's a way of thinking. And also in a just culture, because we do believe that human error happens, we don't discipline people for human errors. We don't get them in trouble. That's not a just culture. That's the first paradigm. The second paradigm that I want to talk about is something called drift. And so philosophically, drift is described as a slow and insidious deviation from an intended course. And so drift is when employees over time stop following policy and procedures, and they have small deviations or shortcuts that are used to save time, and then slowly it becomes routine. And so the risk with this is that over time these small changes become normal to us, but sometimes if we're not careful, they can actually create risk, and then they can create harm. So what I want to do is look at the people in the picture, and I want you to let's look at the first one and the people in the boat. And so can you look and see some things that maybe they're doing that aren't safe, that aren't really standard policy? So just look. So you might see that the person in the boat's not wearing a life vest, that the little boy is turned around, and see, they're drifting what's from the safest thing, wearing the life vest, keeping your eyes and your body turned forward, because probably they've gone without a life vest a lot and nothing bad happened. And then that's slowly normalizing the behavior. And then look at the second lady. She is doing some things that probably aren't so safe. She's only got one hand on the wheel. She's probably looks like she's drinking hot coffee, and she's not wearing a seatbelt. And again, it's probably normal for her because she does it all the time and it seems safe. But the thing is, drifting does happen, and it happens a lot. And so we have to be careful because drift is different from human error. Drift is actually a choice that we make. So we choose to drift. Sometimes we even do it unconsciously though. And so we need to be careful when we start to have these drifting behaviors. But still, with a just culture, just like human error, we don't discipline drift. We do something different. We try and correct that behavior, and we try and readjust so that people understand that this is not the best practice. We need to get back in line and start following those rules and things that keep patients safe. So we've kind of discussed the two paradigms about human error and drift. So now let's discuss how in a just culture we apply these concepts when we need to make decisions about whether or not we need to discipline employees. So the criteria that we use to determine if discipline is warranted is really important for us to understand. So we're going to discuss these three criteria and select the one that is consistent with just culture, okay? So let me tell you about an example. We're going to look at the outcome-based strategy. So let's say we have a nurse and she overdoses a patient with morphine, and that's the same, that's a medicine that helps with pain, and the nurse is supposed to give 1 milligram, but she gives 4 instead. And the patient experiences respiratory depression, so their breathing kind of slows down, but they just take a nap and then they end up waking up. But then we have another nurse, so she also overdoses the patient with morphine, but her patient actually has a kidney disorder. So instead of her patient just kind of being sleepy and taking a nap, her patient actually quits breathing altogether and dies. So if we use the criteria that whatever the result is, that's how we're going to discipline. Is that fair and just? So would we say, well, the lady whose patient dies, that was the outcome, they should be disciplined, but the lady whose patient didn't die shouldn't be disciplined? Is using outcome-based discipline techniques, is it fair and just, or is it not fair and just? and it's not fair. We shouldn't base it on outcomes. What about rules? We have lots of rules and policies, and shouldn't we follow the rules? And the answer is yes, but sometimes we may have to break a rule to do what's best for our patient. So, because sometimes rules are outdated or maybe they don't apply anymore. And so there may be rules that are not justly executed. So we can't just say, well, did they follow the rule or not? And if they didn't, then we're going to discipline them. That's not really a just culture, and that's not really fair. So we don't want to use rule-based discipline. So let's think about risk-based strategy when we're disciplining. So we're going to say that really disciplining based on risk is the best strategy to discipline, and it's the most fair, and it's the most just, and it really goes into a just culture. So we're going to discuss what that strategy looks like on the following slides, but know that the duty to avoid causing unjustifiable risk of harm is the highest duty owed. And so let's take a look at risk-based. And again, risk-based is what we're going to consider fair and just. So let's look at each of these activities on this slide. So in picture 1, you see Steve Irwin, and he is holding his infant daughter and he's feeding a crocodile. In picture 2, we have a patient, and a lot of people have heard about ECMO, and it's really where the blood is circulated outside of the body and all the oxygenation takes place, and it has really a significant mortality risk. And among those who require ECMO for respiratory failure, it's estimated that only 60 to 70% of those patients will die. So it's a really high risk. So both of these situations have a lot of risk, but which one of these situations has a justifiable risk? And so it's really kind of hard to justify number 1. It's probably not safe, and it's really not justified that you should be feeding a crocodile while you're holding a baby. But look at number 2. Even though there's a really high risk, we think that's justifiable risk because we know that ultimately that could be a life-saving procedure. So that's kind of based on the risk involved. That's the strategy that we want to take when we're looking at discipline. So let's examine 3 separate behaviors and determine the appropriate organizational response that's consistent with just culture principles. So let's see what is the best response in an organization that is highly reliable. So let's talk about human error. Okay, so we'll look at human error first, and then we're going to talk about at-risk behaviors, and then we're going to look at reckless behaviors. So that's what we're going to do. So let's start with human error. Okay, human error. It's an inadvertent mistake, cognitive slip, lapse that causes an outcome other than intended. So let me talk about an example. So in this picture, you see a nurse. She's going to pass medicine. And the nurse knows that she has to go to the patient's room, she has to scan the patient's wristband, then she has to scan the medicine, and then she gives the medicine to the patient. Well, the nurse is in this process. She's gone into the room, and this happens to be a room, and there's 2 patients, just like at the VA. There's 2 patients in the room, or at least in our VA. And she goes ahead and she scans the patient, it's the right patient, she scans his medicine, and then all of a sudden, she hears, "Help, help," coming from the hallway. So she goes out, she helps this patient that's fallen on the floor. It takes her about 10 to 15 minutes, there's a lot involved. And then she says, okay, she gets that patient taken care of. She's like, oh, I've got to go finish giving my medicine. So when she returns, she's like, well, I've already scanned the medicine, I've already scanned the patient, let me just go ahead and give him the med. I got to hurry him behind anyways. Well, unfortunately, the nurse gives the medicine to the wrong patient. That is an example of interruption or distraction that caused a human error. So what should our organizational response be to human error? So let's think about this. Did she choose that behavior? Did she intentionally give medicine to the wrong patient? No. Did she even see the risk when she was doing it? No. And so what should our organizational response be? And it's to console. So we want to alleviate grief, sorrow, or disappointment, and we want to provide comfort and solace because we know that was not intentional, and that is how we respond to human error. let's look at how we respond when people have at-risk behaviors. And then when I say at risk, we're kind of talking about those drifting behaviors, you know, when you kind of consciously kind of normal drift away. So let's look at this. So this person is driving down the interstate like we all do, and the speed limit's 70. We know the speed limit's 70, but we might do 77, 78. And so we've kind of drifted. And so are we aware of the speed limit? Yes. But do we really see the danger? So we did choose that behavior. We did intentionally choose to go over 70, but did we see the risk? Yes and no. We really probably saw there could be some risk, like maybe get a ticket, but do we really think that we're going to be injured or severe harm come to us when we drift? No, we really don't. So what is the organization's response? What is the best thing that the organization should do? This is where we need to coach, we need to teach, we need to supervise, we need to train, give instruction. And that's how, when you train them, you train people up, and then they don't cause harm to the patient because they've been trained and they behave correctly. So that's how we should respond as an organization. Now, let's talk about our response to something called reckless behavior. And reckless behavior is when an individual makes a behavior choice to consciously disregard a substantial and unjustifiable risk. So let's think about, look, you can see where if someone says, I'm not gonna wash my hands, or especially in these times, you're like, I'm not gonna wear my mask. I'm not gonna wear it. I don't care. I'm gonna go in that room and I'm not gonna wear it. I don't even care that I work on the COVID unit. I'm gonna stand out here and I'm not gonna wear my mask. Or let's look at there in that picture, there is a foreign object. It's kind of hard to tell that's been left behind. Because let's say the physician in that OR, that room, he was just tired and he said he didn't want to do the timeout and make sure that all the instruments are accounted for. That's reckless behavior. And this is another example. So reckless behavior, when the speed limit's 70 and you're going 130, that's pretty reckless. Do you think that we just can coach a person through that? What do you think? How should we respond for something that's reckless? First of all, do we consider, did they choose this behavior? Yes. Did they see the risk? Yes. Most people, when it's reckless, you know it's reckless. And then what should our response be? And this is where we do have to discipline. So I don't want you to think in a just culture that discipline is not a thing, because that's not true. Discipline, you have to have discipline. That's just the reality of life, because sometimes things really are reckless and you need to discipline. And so these are how we coach, and this is how we teach, and these are the response that we're going to have in our facility to these behaviors, and this is what is going to create that just culture. And hopefully, if we know that when we make human errors, or maybe even if we're drifting a little bit, we don't have to be hiding those, and we can be open about them, and then we're going to be able to change our behaviors. Okay, this slide, guys, it's really just a tool that's going to help support decision making whenever the decision as far as discipline goes. It's really something that leadership would use. So it's just a tool that's there, and it is available if you are a supervisor, if you are in that role and you're trying to figure out what do I need to do with my employee. That's something that you can utilize. Let's go over a few other tools. So far we've discussed what an HRO is, what it looks like for us in the VHA, and then how do we foster a just culture. So now what we're going to do is we are going to review a few tools that we can use to kind of put into practice. So how can we practically begin to foster a just culture and then actually have an HRO? So the first practice that we can use is to speak up when we have a safety concern. So we're going to do something called stopping the line. And if you think about this term, stop the line, it really comes from like a car assembly line. So if you're standing on a car assembly line and they're all working and everyone has a role, everyone has to check whatever piece that they're whatever piece of the car that they're assembling and make sure everything looks good. And if you find that something doesn't work right, well, then what do? You stop and you say, nope, this isn't working right. We got to get this fixed. And that's what our goal is. If we see something that's not safe, we got to stop. We got to speak up. And so simple tool that makes it easy for everyone is to use the 3 W's. And if we use the 3 W's, this helps us. Even if you're more of an introvert and you're more shy, you are empowered when you use these 3 W's. So it's what I see, what I'm concerned about, and what I want. I'm going to show a video and we're going to see this is somebody using the 3 W's. Let's see how it plays out.
Yeah, I can't believe it. I finally got off early on Friday and I went and saw the new James Bond movie. It was really awesome. Yeah, I can't believe it. I finally got off early on Friday and I went and saw the new James Bond movie. It was really awesome. Get a chance to try to see it. What are you and Brian doing this week?
You know, we got a family obligation, but I'm out to try and see that Bond movie. I love James Bond.
I would recommend you see it. It's really a great movie. Let's check in on Mr. Johnson, okay?
Hey, Doc.
Yeah.
What I see is you're about to enter this isolation room without putting on personal protective equipment. What I'm concerned about is you might spread infection to other patients, and what I'd like you to do is stop and put on personal protective equipment before you enter the room.
Wow. Okay.
So although sometimes people kind of chuckle and think, oh, I doubt somebody working in maintenance or housekeeping would ever approach a doctor, the truth of the matter is they should be able to, and they should feel empowered. And you say, if you see something, you say what I see and what I'm concerned about and what I want. And then that is going to hopefully allow us to have a safer environment. One of the things that we want to avoid when we're trying to communicate and trying to have an HRO is we want to avoid hint and hope. And so by hint and hope, think about this. Look at this picture and you say, boy, that grass is really getting tall out there. And you're saying that to your child, your son, your husband. Well, what are you doing? You're hinting that, golly, the grass is really, really tall, and you're hoping that they're going to maybe cut the grass. And this is really something that we want to avoid. We don't want to do the hint and hope. We would want to say, what I see is the grass is really tall. What I'm concerned about is we're gonna get snakes, or my neighbors are gonna not like us. And what I want is I need you to cut the grass. I want you to cut the grass today, okay? That's what we need to do, is we need to speak up. And it's our duty to speak up. If we see something, we need to speak up. It's our duty. And so just like in our video, if it's in a clinical setting, you know, we don't want to say, if we see somebody like in the video where the doctor was said, you know, told to and reminded that he didn't put on his PPE, we don't want to just say, if that was, well, if the person would have said, well, aren't you forgetting something, doc? He would probably have been like, nope, and he would have walked on in. But so really and truly, it's our duty to speak up. And just like in the video, we would say, what I see is you forgot to put on your PPE and that patient's on isolation. And what I'm concerned about is you might catch an infection or get infectious organisms on you, and you can bring it to the next room. And what I want is you to do what that sign says and to put that PPE on. And so that's really important, and we really speak up. Another tool or action that we can do is report errors. So regardless of whether we share concerns via the 3 W's, if we see something or witness an error and it reaches a patient, we have to report it. So we have a system at the VA, and it's JPSR, or Joint Patient Safety Reporting, and that is where we report something. And so really, in order for an HRO to be effective, we depend upon engaged staff members who actively report events, because we can't fix something if we don't know we have a problem. So anyone, if you have a PFE card, and even if you don't, there's, I believe, a downtime form, you can enter it into JPSR. And staff members are encouraged to use their name in case they needed to ask you questions. It's an option that you can do it anonymously. And so what they do is they take patient safety data from the JPSR forms, and then they can make improvements to systems, processes, and conditions. So we can report and we can fix problems. So when reports are made through JPSR, then there's a thorough process done to determine if that report requires an RCA, or a root cause analysis. And so this is a process that's formally chartered by leadership, and what it does, it really goes through the process of determining the causation of the event, and it's designed to resist the tendency to oversimplify an issue and just say, well, it was just that one person. And it really looks at, no, look, this is deeper, this is a process system. And so if you are ever given the opportunity to be involved in one of these RCAs during your career, we really encourage you to participate, because they're great opportunities to be a part of an adverse event and the investigation, and to figure out what exactly happened and how can we prevent this from ever happening again. Okay, so we've talked about 3 tools that we use to support a culture of safety. We talked about speaking up using the 3 W's. We talked about reporting using the JPSR, and we talked about the root cause analysis. And so another thing, though, that we can do as a team is something called clinical team training. And what this training does is it teaches team behaviors that manage threats and errors at the front line. So the team is taught ways to act, and the team is trained in a team unit, and then what they do is hopefully you can mitigate the consequences of error, and you can trap the error and you can avoid the error. So this is going to be a training that may come out, and just be on the lookout for it. And if your unit does it, then great, it's a wonderful thing. So remember, we talked about the 3 pillars of HRO. We're going to talk about that now. So the 3rd pillar is something called continuous process improvement, or CPI. And so what we're doing is, once you've identified risk or problems in your work environment, the continuous process improvement helps us, these tools for continuous process improvement helps us close the holes. And so it's just really something that we need to do to hopefully fix errors and processes. And so one of the things is we want to think with lean tools. And so it's really just tools that help foster a just culture. And so we're going to talk about some lean tools, and it's a way of thinking and acting for the entire organization. So let's look at some tools. So we have something called the 5 whys, and we have something called the fishbone diagram. And so we're going to talk about these 2 things and these 2 tools. So let's look at the tool where you use 5 whys. And this tool is important because on average, it takes 5 whys to get to an underlying cause, hence why we have to keep asking why. So let's look at an example. So we have a problem of a patient keeps waking his roommate up at night. And so we could just say, well, that's because this man's not nice, or he's got problems, and we could just say he's just not a nice person. But we should ask why. And so we should say, well, why does the patient keep waking his roommate up at night? Well, the patient has his television on too loud, and that's what's making the roommate wake up. Well, why does he have his television on so loud? Because he can't sleep. Well, why can't he sleep? Because the room is too bright. Why is the room so bright? Because there's a glare from the nurse's station. Well, why is there a glare from the nurse's station? Because the nurse's station light dimmer is broken. And there you go. There's your problem. If we fix the light dimmer, then we can fix all of those problems, and that's using the 5 whys. As we close off this section of training, let's look at another example of a lean tool and another HRO tool. So this is a story of a care team from the mental health unit at Sioux Falls VA Medical Center, and this is a team who applied the tenets of a just culture and continuous process improvement methods to drive improvement. So during a standard 15-minute rounding on a locked mental health unit, there was a mental health nurse who found a roll of large plastic trash bags on a handrail within the mental health unit. And this was a problem. This presented a suffocation risk for the mental health patients. And after this event, the Sioux Falls team staff, they collaborated and they did what was called a fishbone analysis. And that's where they explored the systems and the factors that led to this roll of trash bags being left on the handrail, creating a suffocation risk. Because if you understand what I'm saying, in a mental health unit, someone may see those trash bags and that's what they may use to harm themselves. So this is a serious thing. So this team got together and they figured out what's going on. And so they used the fishbone diagram. Let's look a little deeper now at the fishbone diagram. So for some simple improvements, the 5 whys may be enough, but often you can find multiple root causes that require multiple solutions to fix. This is when a fishbone diagram could come in handy. So a fishbone diagram is really just a visual way to look at cause and effect. It can be helpful in identifying possible causes for a problem that maybe you otherwise wouldn't consider. So what you're going to do is you're going to identify the problem, write it out in a box on the right-hand side of the page, then you draw a horizontal arrow feeding into the problem. Then you are going to consider what causes might be associated with your problem. And then typically these are going to fit into categories of equipment, processes, people, materials, environment, and management. And from each of these categories, you're going to draw a diagonal arrow feeding into the horizontal arrow, which are the bones of the fish. And then lastly, you're going to consider what primary and secondary causes fall into each of these categories and write them as arrows feeding into each category. And so now you're going to look, remember our example of the mental health team. And so you see the team found a lot of risk and ways to improve the unit, and they broke it down into 3 categories. And so you kind of see some quick examples. So if you look under equipment and materials, they located that there were trash bags in multiple locations, including pockets, and that maybe made it easy to set it down. And then they looked at processes, and there really wasn't a process for maintaining or tracking cleaning supply inventory, and there was no inventory checklist. And then they looked at people, and there's a bunch of different EMS people rotating through the mental health unit, and there was no trainings, and it was kind of the mental health staff and the EMS staff, and they weren't communicating. So they identified these problems, and then based on that, they were able to go back and fix things. So you kind of see some of the things that they did to fix, and that's really what these tools are for. You can identify the issues, really think them through, not just say, oh, it's one thing or one person. You identify the issues and then think them through and think of ways that we can fix it. So what's next? So I want to wrap up. As we kind of wrap up, I want to emphasize that becoming a high reliable organization, it's a journey. And we call it a journey because we don't have an end date. There's no date where we're good and we're fine and we're where we need to be. We can always get closer to zero harm. We need to make small improvements every day that can result in a large benefit for our patients. And today's training is really just the tip of the iceberg. There's a lot more information and lots more training that you're going to see coming in the future. And these are just some things that they're working on. They've got stuff for leadership. Remember, there's 3 pillars. There's stuff for leadership. There's stuff for the culture of safety. There's stuff for the continuous process improvement. There's lots and lots of stuff that you're going to see that are always going to point back to making it a safer organization and a just culture and things that we can do to make ourselves better, because ultimately we really want to be zero harm. And so think of some things today as you leave this training of what can you do? How can you help become a more highly reliable organization? And there's some things you can do. You can speak up. Don't be afraid to speak up. You can report these events or errors, and you can try to help get to the root cause, and you can make continuous process improvements. So those are some things that you can do. I mean, and remember, when you speak up, use your 3 W's. Those are all things that you directly can do to help our organization. So as we close, I do want you guys to continue to think about what is that one behavior, that action or process that you're going to commit to so that we can become a more highly reliable organization. And I want to say thank you for attending this training. And like I said earlier, you will receive credit in TMS, and I do appreciate it. And thank you for going on this journey with us. And I hope that we really can get to zero harm for our patients. Thank you.